Hey, you know, this panel is a little bit different from some of the other panels you're going to see today. Many of them have to do with some of the biggest, toughest issues facing the globe today, sanitation and water. But why the misuse of prescription drugs? Well, it goes back to President Clinton himself. 2 years ago, the son of one of his very best friends, a young man named Benjamin Gupta, took an Oxycontin. He was studying. He was just about to get his law degree, and he mixed that with a drink. He ended up dying of an overdose. He never woke up. And President Clinton said, you know, this is so preventable. This is so addressable by every single person in this room, every single person on a campus. And he decided that Clinton Global Initiative University and the Clinton Foundation would focus on this issue. And that's how we come to be where we are today with this amazing panel. We have some of the top people from the White House, from advocacy, from prevention and treatment. Let me introduce them to you. Joining me right here is Michael Botticelli. He is the Deputy Director of the White House Office of National Drug Control Policy. Michael has been in recovery himself for 24 years from alcohol addiction. And he's no stranger, even though he's in the White House now, he's no stranger to dorm life. For a decade or so, he ran dorms at Brandeis University. So he knows what it's like to be in college campuses. And he helps oversee the policy across many, many different strands of our government. Sitting next to him is Sarah Nerod. Now, Sarah is an amazing young woman. She's getting her master's at OSU right now. She's 5.5 years into her own recovery, but she also is the founder of a national advocacy organization called Young People in Recovery. And she runs her own consultancy called Prevention, Treatment, and Recovery Associates. She's studying to become a licensed alcohol and drug counselor. Sitting next to Sarah, a man who needs no introduction, Matthew Perry. You know him perhaps from Friends, from his hit series Go On. I saw him on Good Wife. But what you may not know is that Matthew is also an advocate. He has been named the ambassador for the drug courts, the National Association of Drug Court Professionals. And as such, he has been lobbying Congress, as I mentioned, for better policies and more support for drug courts in this country. Sitting next to Matthew is Dr. Laura Brown. Now, Dr. Laura Brown is herself a pain meds doctor. She was in Florida, and she was so concerned about what she was seeing in the practice, these pill mills where you can go and get pills kind of on demand, that she started to work with the state of Florida. The governor asked her to join a panel, and she was able to put in place laws that monitor drug prescriptions more effectively. But she wanted to take it further. So she became the medical director of the Pain Truth. And they launched something else that each of you can take part in, a new campaign called Wake Up. So thank you for joining us. You know, we want to start by talking about the issues involved from a personal, I think, and from a 3,000-foot view. So, Sarah, I want to begin with you. You know, when I was talking to each of you, 3 of you are in recovery, each of you said to me that addiction is not a crime. Addiction is a disease. And some of us are more susceptible to this disease, just like we are to diabetes or cancer, than others. Now, Sarah, you were 12 years old when you first realized that drugs was something you wanted to try. And it was a pretty fast descent from that first drink your freshman year in high school to the day when you were ODing on ecstasy as a sophomore. And your parents took you directly to recovery. I mean, to treatment, to try and go into rehab. Tell us what happened.
So I find myself I'm 16 years old, and I'm in drug and alcohol treatment for the first time. And I had no idea what this was, what these words meant that they were telling me: powerlessness, sobriety, anonymity. I had no idea what any of this meant, and it's very overwhelming. It was very scary. And when I get out of treatment, I didn't do anything to make it stick. I still hung out with the same friends. I went to the same parties. And I felt like this label had been put on me. You know, that everyone knew I just got sent away to treatment, and I was angry. So I felt like, well, I'm going to show you a problem now. And my drinking and my drug use got significantly worse coming out of treatment. And I went back out, and it did. It was horrible. It was much worse. But going back out enabled me to hit a bottom sufficient enough for me to realize I have a serious problem. And being able to drink and use drugs recreationally isn't an option for me. So I found myself, I had just turned 17, entering my second treatment center. And fortunately, I was willing to open my heart and my mind to listen and make a change for myself.
Thank you, Sarah. Matthew, you were in what you called the white-hot flame of fame. Every week, 30 million Americans and people around the world were tuning in to watch you on Friends. You have your first big movie, you're in Las Vegas, you're water skiing, you hurt your back in a water skiing accident, and a doctor prescribes the first Vicodin for you. Pretty soon, it's not one Vicodin, it's 55 Vicodins a day. Talk about where you were at that point and where you've come, what you've learned.
I'm just remembering what it was like to have 30 million viewers. Yes. Yeah, I was doing a movie. A doctor in Las Vegas prescribed Vicodin, and I took it and felt this better than I'd ever felt in my life. I felt euphoric, and you know, I had the gene. I had the alcoholism addict gene, and that over the course of the next year went from 1 to you know, a very high number of 55 a day. And within about a year, I'd gone to my first treatment center. You know, and it was showing on me too. I had a friend said that I had returned to my original birth weight, and that's where I heard the first words that that it wasn't my fault. It wasn't my fault that I had a disease, and I believe it was labeled a disease, American Medical, in 1955 or something like that, Earl? Something like that. And that there was a solution to it, and I fought it very stubbornly for years until I finally surrendered, and so, you know, broad strokes, that's what happened to me. You know, I didn't want it to happen to me. I didn't, you know, nobody wants that to happen, but you get involved in something that's bigger than you, and it isn't until you surrender and take yourself out of charge of your own life that you're able to make some changes.
Now, this was kind of a secret. You know, you're a big movie star, you're a big television star. You told me that a friend stepped in, saved your life.
Yes. Yeah, it was a secret. People don't... I needed it to keep a secret. You know, that's the thing that's very difficult, because addicts, as a rule, lie. You know, they don't tell the truth. They lie about this because there's a lot of shame. They need to protect their habit, so they lie. And it takes a very strong person to break through that lie. And I had this friend who said, "I know something's going on with you," and I just burst into tears. I just burst into tears because somebody punctured the membrane of that lie, and then I was able to get help, and that person was very brave. And had she not done that, I wouldn't be here today.
I bring this up in Matthew's long story because each of you could be that person. Each of you may know somebody or be that person. And I want you to listen to the stories and think how it applies to your life and to those you know. Dr. Laura Brown, one of the things that strikes me of Matthew's story is, boy, it takes a lot of doctors to amass 55 Vicodins a day. Is this part of the problem?
It absolutely has been part of the problem. You'll notice, if you look at the data, that the trend and increase in deaths due to prescription drugs kind of started in the year 2000 and then escalated through the year 2010 and is still rising. And we see that because that time period was when we as a country established that decade as the decade of pain. And it was done by the medical community as a very, good-intentioned thing, because we knew opioid medications helped cancer patients, and we knew patients that didn't have cancer had chronic pain, and we felt that opioids would help them as well. And there was a misperception that opioids weren't necessarily addictive if somebody had pain. Well, it's taken us 10 years to learn that that was a poor decision, and that's a big reason why we are where we are. Not only that, there are also a lot of unscrupulous doctors out prescribing for money, and they shouldn't be doing that. That, quite frankly, is illegal. And then one of the big problems is because of this decade of pain, we were encouraging the medical community to prescribe without giving them the tools they needed to understand the drugs they were prescribing. So there's a real knowledge gap in the medical community about many of these drugs, which is why organizations like the ONDCP are stepping up to provide national standards for physician education, which I think is very important.
Tell us about what you started, the Pain Truth, and why you started that.
Yeah, I was a pain physician. I was working at a state level trying to advocate for our specialty, because at the time, everybody in Florida was associating pain management as pill mills. And I don't know if you guys know, but we were the nidus of the problem in the state of Florida. We had thousands of pill mills across the state, and people were coming from other states into Florida to get pills and then take them back to their states and sell them. It was a really bad problem. Since then, we've gotten a handle on it. But at the time, we were trying to address this problem by creating a public awareness campaign to educate the public about pill mills versus legitimate doctors. I got numerous phone calls from parents mainly, but I got them from all kinds of people, but parents saying, I don't know what to do, my child's addicted, I don't know where to turn, I'm concerned. Or the call that really wrenched my heart were the calls from mothers that say, I went in to wake my child up, and I couldn't wake them up. They had overdosed in their sleep. So, with that, we decided that we needed to do something, me and my team, we needed to do something. And we felt the way to address the epidemic was through education and prevention. And the only prevention that would really address this problem effectively was prevention of first-time use. And my research proved to me that there was a knowledge gap among young people. I believe young people are smart and by and large make good decisions if they're armed with the correct information. And there's a knowledge gap. For example, we talked about your addiction at age 12, and Matthew said he has an addiction gene. Well, many of you may have an addiction gene, but do you know that your brain continues to develop until you're in your mid-20s? And during that time, you're at a significantly higher risk of developing addiction with just experimentation. A switch can be flipped within the addiction center of your brain, especially during those years, and you can be an addict, just like somebody who is genetically predisposed. So there's an increased risk among young people. They don't have that knowledge, and that's one of the things that we wanted to do, was to arm them with that kind of knowledge.
Michael, let's talk about this. We're calling it an epidemic. Is it?
It absolutely. So the Centers for Disease Control has talked about this as an epidemic. And, we talk about the devastating impact, and some of the figures came out. So in 2010, 16,000 people died of an overdose, of a prescription-related overdose. And the way that I translate that is that's 44 people a day that are dying. When I was in Massachusetts, 2 people a day were dying from opiate-related overdose. And it's huge. And that has actually surpassed motor vehicle fatalities as the second leading cause of injury death behind suicide. It's huge. And, so let me ask a question. How many folks here know someone who's overdosed from a pain medication? It's wild. And so how many folks know someone who's used a prescription medication non-medically? And I'm including Adderall here, right? Okay, so significant issue. So, Matthew's right. This is like the last big secret that we have relative to the things that we do. And, Laura talked about education. So, I've been in recovery for a long time. I come from an alcoholic family, as many of us do. And so I am one of those people at risk. And it's not just about education. It's about how do we ensure that we are identifying at an early stage people who are at risk and who are starting to do risky use, right? So I'm a college kid. I drink my face off like everybody else does, but some other people stopped and I didn't, right? But I don't remember a primary care physician, a school counselor, an RA, anybody intervening early in my disease. I always say that addiction is the last disease where we wait till people reach their most acute condition before we decide to do something. And for many of us, it's often intersection with the criminal justice system that prompts that interaction. So it's amazing. And you know, the other piece that I talk about as well is that the treatment rate for those with an addiction is only about 10%. So only about 10% of people who have a diagnosable condition for substance use get treatment, compared to diabetes, which is about 85%. So not only do we have this huge knowledge gap, but we have a system that basically doesn't do any early intervention and quite honestly doesn't really look at appropriate access to treatment. So that's where our office comes in terms of setting kind of national standards around education, trying to implement screening and brief intervention programs. One of the most innovative things that we were doing when I was director of substance abuse services in Massachusetts, there is a very safe, easy to administer antidote to overdoses, and that's called naloxone, used by first responders that reverse an overdose. And an overdose, your breathing stops over time, and naloxone immediately reverses it. And so we worked with law enforcement, we worked with parents, we worked with our needle exchange programs to train people to reverse an overdose. And as I left, we had trained over 15,000 people throughout Massachusetts and reversed over 1,500 overdoses. And so part of that's happening is nationwide as folks are looking at, and part of our strategy nationally is how do we expand these overdose education programs.
Thank you, Michael. Let's talk, panelists, about the truths and the myths of prescription drugs. Throw some out there for us. What are some of the big myths?
Oh, I'll start that one. You guys all raised your hand when he said you knew somebody that has abused prescription drugs, including stimulants. You know, there's a #1 drug of abuse right now on college campuses are stimulants, and there's a real belief that stimulants are safe and healthy, and that's a myth. Stimulants are not safe, they're not healthy, they're addictive, they're formulated cocaine, if you will, and they may help you perform initially, but not in the long term.
So by stimulants, you mean Adderall, what else?
Adderall, Ritalin, Concerta, Vyvanase, those drugs. You know, and I challenge everybody in the room, if you want to take something back to your campus, I challenge you to go back to your campus, address your student government, and start an academic or write a new academic integrity policy that includes the use of prescription drugs or the abuse of prescription drugs, including stimulants. It's not fair that some folks are using these and other kids who are trying to do the right thing aren't, and they're still competing.
What are some of the other truths you would like these folks to know?
I know one thing that I was always concerned about was where are my drugs coming from? And I thought that prescription drugs would be cleaner. You know, they weren't being smuggled, you know, from Mexico, you know, under a bunch of like dead fish, you know. So that was something I thought about when using drugs, and when I talked to other people, they thought that these are going to be much cleaner. They're not going to be, you know, smuggled in all these gross places, but that's not necessarily true. Because I think about the times when I wanted to sneak drugs places and the ways that where we hid them on our bodies, on things that we were carrying. So it's still kind of disgusting sometimes where we get our drugs from, but yet we don't think that that applies to prescription drugs. We only think that applies to street drugs. So you don't necessarily know where that pill was kept.
Yeah, I would say a big rationalization that occurs is when you're taking quote-unquote legal prescription medication that you're not breaking the law, that somehow it's safer. I think that's the main point, is that it's not. People are dying. People are, you know, you spoke to it. Opiates. Eventually, what happens is they shut down your respiratory system. So taking OxyContin is just as dangerous, if not more dangerous, than taking street drugs, you know, off the black market.
I think it also happens in a context where we, as kind of consumers of healthcare, feel like, I have a problem, take a pill. I have a problem, take a pill. I have a problem, take a pill. That we don't look at other holistic remedies to what we're doing. And plus, it happens in a context of direct-to-consumer marketing for pharmaceuticals. So, you know, here we're inundated on a daily basis with advertising saying, take a pill, take a pill, take a pill, take a pill. And we as consumers buy it, in essence, that we don't look at other kind of healthier ways to think about expressing our lives.
I get that as a physician in the medical practice. I'll get patients that come in and demand a prescription. And I'm like, well, wait a minute, you don't need that prescription. Let's try some other modalities of treatment.
So how do consumers react to that when you say that?
I've never heard that. Never.
Well, it's tough. It's tough as a physician that's trying to do the right thing because we have a generation, as you said, of people that expect a pill to fix every ailment. It's a tough thing.
And you're the generation to change that.
Absolutely.
Let's talk about change and what each of you in your own realms are doing to change and solve some of these problems. Dr. Laura, you're focusing on prevention in 5 high schools across this country. What are the hallmarks you found of good prevention?
Well, we just completed a pilot program in 5 schools, 3 in San Diego, 2 in Florida. We had outcomes data recently, and we learned a lot of things from that. One of the most important things that we learned is that we've got to listen to our target audience. So we created an advisory board made up of students, 13 to 25, from all across the country we worked with for over 2 years. We vetted everything through them. So we found out what are the issues that are important to you. You know, what are the things that are happening on your campus? And we kind of incorporated those into our program. So listening to our target audience is very important. Integrating within the community is incredibly important, and we've tried to do that in our program. And then creating sustainability. The program can't be something that comes in for an hour or two and leaves. You know, we have to have a presence, and we have a presence for several weeks in the community, and we try to integrate, and then we leave something behind to maintain that sustainability. That's the core group of students that volunteer to work with us. And every school we went into, our core group actually doubled in size. And they continue to stay involved in our program through social media outlets that we've developed. So I think those are important. Understanding the audience and what their target population and what their needs are, and incorporating, using them, letting them be involved in developing the program, working within the community and being very comprehensive, and then creating sustainability.
Michael, what kind of techniques do you think are effective on college campuses?
So I think there are a number of things that are really important. And one is, you know, we often talk about kind of the science of prevention. We know that things work and certain things don't. And getting someone up there telling their horror story about their use usually does not work. But, you know, things like developing social marketing campaigns to change the norms on college campus. Quite honestly, not only about prescription drug use, but about binge drinking as well, because the two go hand in hand. But, you know, thinking about changing the cultural norms on college campuses. Things like working with college health services to look at, do they have naloxone? Or training folks on campus to carry naloxone in the event of an overdose. Looking at things like developing screening and brief intervention protocols within your college health services, or having the RAs, quite honestly, or the hall directors trained in terms of identification and intervention. You know, Matthew talked about the critical role that intervention, and I think all of us know that at some point, someone or something intervened in our lives. So I think that there are many, many things that folks on college campuses can do to really look at what is the issue, how do they develop prevention, intervention, treatment programs. I think are really important, both on campus and within the community. So we have wonderful medications for opiate addiction that are incredibly underutilized. And so how might you work to expand the number of physicians who are trained to do opiate treatment, both on college campus and within the community?
I think the important part of that is getting rid of the stigma. I mean, how many of you guys, when you walked in the room, when you think of addiction, does that come with a negative connotation to you? Yeah, it does. It does across all segments of our society, including the medical field. I mean, many physicians are afraid to treat somebody with an addiction. They don't know what to do with it. So I think not only education, we've got to, and through your media outlets is a great way. We've got to really eliminate that stigma, because it's a disease. It's not anything to be ashamed of.
You know,
Well, we also a lot of times think it's older people. I had a really hard time at 17 realizing that at that age I had this thing. So I think that's a struggle with young people, that it's young, old, middle-aged, just everybody.
Talk about your work in the courts, Matthew, because as Michael said, too often the first time it really gets addressed is when you're in front of a judge.
Yeah,
You know what's funny about the OD pill that you're talking about? See, I'm the kind of addict, I would OD on the OD pill. That's the problem. I'd be like, that made me feel something, I'm going to OD on that. But
No, you wouldn't.
No?
You don't know. No.
I'd figure out a way. From the addict's point of view, the answer for me finally came. I would see all of these people ahead of me turning their lives around, becoming and changing. There's this ideology in society that people never change. Well, I see people change every day, and the way out is no longer living for themselves, living for other people. And I started doing that, not seeing any results really, but because people before me had done that. And a very close friend of mine had dedicated his life to that pursuit, and I did that. And I did that just based on faith. And I said, I see this working for other people. And so I stopped living for myself, and I lived for, I tried to be of service to people. And eventually, I finally got it. I finally understood these existential questions that I would have. I'd be lying in bed going, why are we here? What is the purpose of everything? And I finally, for myself, understood that my primary purpose was to help others and to help other alcoholics and help others. Stop living for myself. I lived the first 40 years of my life for me, and now I'm going to live the next 40 years of my life for you. Not you in particular.
Damn. and you have taken your fame.
Damn.
That's very good timing. It's like we rehearsed that.
Matthew, you've taken your fame and you've gone before Congress to advocate for drug courts.
I get to do that kind of work on a one-on-one scale back in LA, but this wonderful group of people at drug court, I get to help hundreds of thousands of people, and what that is a group of judges across the United States that take first-time nonviolent drug offenders, and instead of just throwing them away into the prison system, they put them in a rehab situation for 2 years, and it's predicated upon the premise that these people would not be breaking laws if they weren't drug addicts trying to support their habit. I broke a tremendous amount of laws, and I don't know how I didn't get arrested, but I didn't get arrested. But I broke a ton of laws, and had I got arrested, I wouldn't be here in front of you. I'd be in jail with a tattoo on my face, you know. Drug court is one of the few no-brainers in society. Everybody likes this idea. It's bipartisan. Republicans like it. Democrats like it. The only people that are against it are private prison owners, and you know. So it's a no-brainer for me. I love doing this work, and I get to help a tremendous amount of people. And yes, I did just go before Congress, which was even scarier than being here. And we got funding for another year for that, and that's a wonderful thing.
$86 million. Matthew helped secure $86 million to support the drug courts nationwide. Sarah, let's talk about your work on campuses, because I think it relates to everyone in our audience. Talk about Texas Tech and what you had there and what you're trying to create, your vision for other colleges.
Absolutely. I was very fortunate that I got to go to complete my undergrad at a school that supported students in recovery, that created and helped fund a safe haven on this campus that has a culture and an environment that's not really conducive to being free from drugs and alcohol. We had our own 3-story building, we had our own academic advisor, we got scholarships, we had free coffee, which is very important for us. We had social events. It was wonderful, and I felt like I had a genuine college experience. I didn't feel like I missed out on anything because I don't drink or use drugs anymore. I still went to concerts. I love rap music. And those shows are definitely not conducive to recovery. But I go to them, and I go to them with people in recovery, and we threw big house parties, and it was wonderful. And I found myself at a school in Boston going to grad school that didn't have a program like this, and I underestimated how vital this support is to me. And I was so humbled by this experience in Boston, and fortunately I felt a calling, and my higher power created an opportunity in my life to go to Ohio State University and start a collegiate recovery community there. So I am afforded an opportunity right now to help all of these students. We have 950 students in recovery at Ohio State, to build a program to support them so that they feel a part of and supported and that they belong. So it's just so amazing to get to do that.
We want to segue to some questions, but tell us a little more detail of what your vision for OSU looks like.
Absolutely. I want us to have a drop-in center that is just for these students in recovery so that they can have a place to escape to where they know that there's going to be other students in recovery here. They can study. Just a safe haven like I talked about. We're also going to have a recovery house so the students can live together. There's accountability. There's staff if a situation were to arise, to really build this community. I also want to fundraise so that we can have scholarships for the students that are in recovery, professional development opportunities, additional academic support, because a lot of us, I might have graduated high school with really good grades, but that was because I cheated. Because I didn't have time to study, I had drugs to do. So on paper, we might look like we've got it together, but we really don't. So specialized supports to kind of fill the gap where our addiction got us into some trouble.
Now we're going to open this up to some questions. And Matt, where are you? Matt's right up here. We're going to ask you to come and bring your question to Matt so you can be on camera. So anyone with a question, come on up.
Hi, I had a question. I was just wondering this is for anybody, when you realized that you had a problem. Because a lot of people who have these kind of problems, they're in denial a lot of the times. And when friends and family do try to come and talk to them and to try to help them, they normally just shut them out and the problem just gets worse. So I was wondering how you realized that you had a problem and how you got helped and what you can say to people who are in denial.
The question, I'm repeating for the cameras, is when did you realize you needed help? How did you snap out of your denial?
So let me say a couple things, first of all. That I often think addiction is the only disease where we ask people to self-diagnose before we decide to do anything to it. So yes, people are in denial, but people are in denial about a lot of things. They're in denial about their smoking, they're in denial about their obesity, but what we do as a culture is continually to do interventions and bring people along. And I think that's what we have to do here. Because unfortunately it often is at that most critical point where people are really, really hurting that someone intervenes. That there are opportunities way upstream before it becomes an issue that people need to intervene. So for me, it took a drunk driving car accident, basically almost killing myself and another person, and it took a judge to say, you have to go to 16 weeks of counseling before I realized I had a problem. Where we could have intervened, there could have been multiple interventions before then, so that you don't reach this state where you're in absolute denial about what's going on in your life.
Next question.
Oh, thank you. To take this conversation to the next end, maybe this is for Dr. Brown, we can get divorced online, we can get our taxes done online, we can do so much work online, and we've got these kids that are doing tremendous commitments. Would we be able to tactically address this problem more efficiently if we had faster adoption of electronic health records?
Absolutely. Yeah, and we're heading in that direction. Technology's there, the healthcare profession is somewhat behind, but absolutely it would help. What we have done, though, in the meantime, is most states, almost all the states in the country, have passed laws now that have created what's called a prescription drug monitoring database, which allows prescriptions for controlled substances to be tracked by the state. It's a tool to be used to help doctors identify people that may be doctor shopping, getting multiple scripts from multiple different physicians. It's also a tool to help improve medical care because you can see what meds that patient's on that they may have forgotten to tell you and prevent drug-drug interactions and things of that sort. Some of the things that need to be done is additional funding for these programs need to be encouraged at a national level, and state-to-state interconnectivity of these different databases needs to happen. But absolutely.
Once again, I'm going to ask you to come to Matt because that'll make it a lot more efficient. But we have a question right up here.
Hi. I just want to say thank you to all the panelists. I think the fact that the majority of you are in recovery makes this a lot more effective in conveying the messages, and you can also just see a level of understanding between you. That being said, a question for Sarah. So you create these communities on campus with students in recovery, but how do you integrate those students with the rest of campus, and how can students that maybe haven't personally gone through this connect with students in recovery?
Absolutely, and I think that is so important for people in recovery to not be isolated and excluded. I mean, I have a lot of friends, probably more friends that aren't in recovery, and I think ways that we can do this with these communities on campus is to take personal responsibility for getting involved on campus. At Texas Tech, I was in different honor societies and clubs. I made friends with the kids in my class, so a lot of it is take personal responsibility, but also from a programmatic level, for me to encourage other students to support and be involved. And I think ways that I felt comfortable reaching out to students in my class that weren't in recovery is by sharing with them. And you would be surprised how many of them would come to me and say, oh my gosh, well, my dad's in recovery, or my brother, he's been to treatment. I mean, we saw the hands raised. I mean, this affects everyone. So by changing the culture on campus where we're more supportive of people making a decision to do something to better their lives really helps all of us to feel a part of one big community.
You know, one of the things, I'm reminded that lots of great social movements have relied on people coming forward and coming out, if you will, about their own issue. So whether it was cancer, whether it was HIV, whether it was about being gay. And recovery is still in the closet, if you will. And one of the things that we used to do when I was a hall director is we used to call them zaps. I don't know what but it was basically people coming out and sitting with a bunch of students on their floor or in their dorm, talking about their own experience, and it really personalized the experience, and so part of what you might want to think about is how do you sponsor people in recovery who are comfortable about it, coming and talking about what it's like, what their journey was like, about how students who are not in recovery can support them. So I think it's a really easy, simple way to think about creating a community of understanding around recovery.
Yeah, it's a very interesting thing because it's so widespread now. It seems that everybody knows somebody who's in recovery, but there's still this ideology that someone who has to go to rehab is weak or is, bad. Their behavior's bad. And I always think that people who feel that way just don't understand. They just don't understand. And to get some education on it, but is essential. But why would you have to learn about it if it hasn't affected you or somebody that you love? Why would you need to learn about it? But anybody who looks at somebody who's in rehab as, oh, that person's an idiot, or that person doesn't have any willpower, just doesn't understand. Hasn't taken the time to read about what addiction is, what the disease is. It's not a matter of will. It's not a matter of strength. Alcoholics and addicts are some of the strongest-willed people you'll ever come across because they manage to take all the rules of society and bend it to exactly what they needed it to be. They're very strong-willed people and some of the most interesting people you know, I barely am able to even talk to normal people. But it's that ideology that frustrates me, because all they need to do is read up about it and they understand that it's not a matter of being weak-willed. It's just a matter of having the disease.
So bringing it out of the closet, talking about it, destigmatizing it are all things that you can help do in your own campuses. The next question.
So a lot of emphasis has been placed on demand for these prescription drugs, but I feel like a big problem is the supply of these drugs. And personally, just my experience, you know, with the healthcare and the medical system is I go in with a problem and I get prescribed a drug that I don't feel like I need. And I think that places a lot of mistrust in the medical system, but a lot of individuals come in with a problem and they don't know another way to address their issue, and so they take the drug because that's the only advice given to them. So I was wondering what is done to being in order to, I guess, solve that problem.
That's a very, very good point. And I'll tell you from personal experience, we go into these schools and we talk to some of the parents, and they're like, I don't understand why in the world my kid went in to get their tooth, a filling filled or their wisdom tooth fixed, and they came home with a box of 60 pills. The parents that know about it are aware, and they're confiscating the pills. But a lot of those parents aren't aware, and thus one source of pills on campus. As a result, we've kind of developed a program called the Wisdom Project, which is going to be healthcare physician education. But to your point, there's still a lot of overprescribing. The pendulum, as I told you, as a result of that decade of pain, it swung way too far over, and it's in the process of swinging back. What we have to be careful of is we don't want it to swing back so far that people who need these medications can't get them. So it's a fine line. Through the works of the ONDCP and different organizations, there are education campaigns that are being implemented now for healthcare providers to stop that overprescribing.
But is that even possible to swing back right now?
Absolutely.
With all the pharmaceutical companies kind of having control with it in those medical systems?
Absolutely. The pharmaceutical companies kind of have a bad name right now, at least the ones that prescribe those drugs.
So first of all, you should come work for our office, because our office really actually looks at this balanced approach between supply and demand reduction, both at the prescriber level, but also at the domestic level, and quite honestly at the international level. So we know that people, if something is available, people are at risk of taking it. So we know that, and we see that with prescription drugs in the medicine cabinet. So, but it is this balancing act. In terms of what of both supply reduction and demand reduction.
Interesting, though, to your point, you guys may know this. If you do, stop me. But the United States comprises of about 4.6% of the world's population. We consume 80% of the world's opioid supply. We consume 90% of the hydrocodone supply. 4.6 of the population.
Now, aren't some of you organizing drug turn-in programs on campuses? Talk about that. And let's bring Matthew his mic back if we can.
Thanks.
So I'll chime in. So one of the things that we've been working on with the Drug Enforcement Agency is what we're calling Drug Take-Back Days. April 27th, there's actually another Drug Take-Back Day. So, one of the things that you could do is work with your local law enforcement in sponsoring campus-based or community-based take-back days. So, one of the things that we also do as consumers is that we hoard our medication, right? So you get a 30-day supply, you take 3, and you put it in the medicine cabinet and save it for another day. And we know that that's often how it gets diverted. So we've been sponsoring, in conjunction with the Drug Enforcement Agency, drug take-back days. So there are things that you can do both on campus and within your community to help support those drug give-back days.
If I'm not mistaken, I think over 600 tons of pills have been turned in on drug take-back days today.
Where are they turning them into?
They're burning them, Matthew.
That's a need-to-know basis, Matthew.
We're going to wrap this session up and head into the table discussions, but I want to ask one last question of each of you. I mean, 3 of the 4 of the folks on this stage are in recovery, some 24 years long. And you've said to me that being in recovery is like being given a second chance at life. What do you want to do with this second chance at your life? Matthew?
Well, I alluded to it earlier. It's pretty simple. I want to live the second part of my life for others, and I want to. I was so uncomfortable in my own skin the first half of my life. I've been granted I am comfortable enough now that I don't need to be focused on myself all the time. And the happiest I am now is when I'm trying to help others. The best thing about me, and I've had a life of a lot of really interesting things happening to me, but the best thing about me is that if somebody comes up to me and says, I can't stop drinking, can you help me? I can look them right in the eyes and say, yes, I can. And then I can back that up and actually do it. And so I want to spend the second half of my life doing that.
Thank you. Sarah?
Well, I guess I'm very grateful that it's not the second half of my life, it's the majority of my life that I get to do this.
Yeah, you got it earlier than I did.
I want to spend the rest of my life creating for other young people in recovery the same opportunities that I have had to really live a full and meaningful life. I feel incredibly blessed and fortunate that I've had opportunities to go to college and not take out a ton of student loans. I've had opportunities for professional development, to get to go to conferences and learn. And all of these things really make my life meaningful to the point where there's no way I'm going to go back to what I used to be doing because my life is so good today. So I want to make that possible for any young person out there that wants recovery and that is in recovery.
Dr. Laura, you're not in recovery, but you have a vision of what you want to achieve. What does success look like for you?
Wow, success looks like less young people dying every day, reversing the trends that we've been seeing. You know, right now the numbers are 2,500 teens between the ages of 12 and 17 abuse prescription drugs for the first time each and every day. It's the latest statistic. You know, success to me would be to see that go away, because most of those kids end up either with addiction problems, and they're not all as lucky as the people on the panel. Many of them relapse over and over and over again, and many of them don't survive. So if we could reverse this trend, that would be a huge success.
Mike, I'm going to give you the last word here.
It's hard for me to talk about this sometimes. 25 years ago, I was handcuffed to a hospital bed, and now I work for the frickin' White House. It's wild.
Congratulations.
What's better?
And my story is not unique. And maybe the White House part is unique. But it's really about the power of recovery. And it's really about what is possible. And none of us are up here in recovery. We didn't do it alone. We had a tremendous amount of help and assistance along the way. And the grand tradition of recovery is you get back what has so freely been given to you. And whether you do that on a volunteer basis, whether you do that on a professional basis, and whether you do that by being out about your own recovery and in hopes that some other person is not going to feel that sense of shame that many of us felt about asking for help. That's what it's all about for me. And I think you have the ability to change that. And you have the ability to kind of create a community of people who both promote good and healthy use and support people in recovery. You know, I think many, many times Katie and I, who works for our office, are talking about, we hear the horror stories about substance use, particularly among young adults, and it's really wonderful to be here and seeing a dramatically different viewpoint in terms of people who are bright and intelligent and are committed to changing this. And you have the ability to do that. And, you know, I hope that from a national level, the work of our office can help support that.
But let's hear it for a wonderful, wonderful, honest panel. Tremendous. Now we turn it over to you to talk about what you can do on your campus. We're going to bring up the question that we're asking each of you at each individual table to address. Here's the question. What actions can you as students take to address the issues of misuse of prescription drugs on your campus? Please, what we're going to have you do is talk for about 10 minutes. Our panelists are going to come in and talk with you. And then we're going to ask some of you to share the nuggets of truth and insight. So don't go away, but you have 10 minutes to talk about this. So it is so great to see this energy and this interaction going on. And I encourage you to continue talking about this long after this panel is over, at lunch, going back to the main campus. But we want to hear from some of you. What are some of the most important nuggets that came out of your discussion? Do we have some volunteers? There's Matt and some others with microphones. Here's one of our volunteers. Tell us, what is one of the most important things you heard?
Is that working? Yeah, sure. We didn't just come across with the problem in the United States. We also discussed about this is a problem in the whole world. I'm originally from Afghanistan, and in Afghanistan, this is a bigger problem with kids that are amputee or have any disability. The families start treating the kids with opium because they feel like that's the only option and they need to relax them. So one of our members said, teaching them how to dose and how much amount can you dose that child based on their weight and their size would be one of the solutions for this problem, because those families cannot afford to take the child to a hospital or pay for the medical bills. So their solution is just to give them as much as opium as possible so that they can be relaxed for a month till they recover. After, when they recover that disability or any problem that they have, they're already drug addict. And they're 7 years old child. So that was one of our solutions. I think this was very important.
Thank you. A global facet. Over here.
Hi, my name is Herschel Shukla from UPenn. While speaking about what the campus can do to address these issues, we talked about the administration's role and how there's a large gap between what exactly administration has set and what the students actually think they can do and not do. So one example at my university that was implemented a few years back was medical amnesty, in terms of many students that may be unconscious due to alcohol and their friends in the dorm room don't want to get help or tell an RA or tell an authority figure because they're scared of getting in trouble or the law. And our university implemented this thing that allows them to go to the hospital without any questions asked and treat them. And this sort of bridging the gap between administration, the rules, and what the student life and activities are actually going on. So.
Very important point. Medical amnesty for the person who needs treatment, and also for the good Samaritan who takes him in for treatment. Really important. Other nuggets?
Yeah, so can you hear? We specifically talked a little bit about educating the youth, and meaning when I say youth, obviously we're educating a lot on those that might be directly affected, but educating like the children of the family members that are affected by it, and one, not only how to deal with it if there is an overdose, and not just educating the parents and officials around, but also the children, because they're our future, and how they're impacted in the next 20 years, because it's a relatively new thing. Can really define that course and that education and knowledge gap that lies kind of in age, I would say, starting at 8 years old to 15 before they even enter college and can be affected by it.
So education for all ages about what to do when faced with overdose. Other nuggets?
My name is Ethan. I'm also from the University of Pennsylvania. So I find that it's really a challenge when people talk about prescription drug abuse to dramatize it as if it's like a Lifetime movie by saying everyone who is abusing drugs is going to OD and die, because the reality is many of us who work in the field of public health realize that people who abuse drugs, prescription drugs, are really high functioning, and they do it on a very elevated level. They just do it to keep themselves going. And so the conversation that a lot of people are recognizing these days is that you have to acknowledge that people can function while they're on these substances, but also abuse comes in many forms, such as mismanaging medication. For example, a lot of my friends who are also grad students, we have really crappy health insurance, right, as a grad student. And so we don't get coverage for prescriptions, and so if we pick up a script, we hold on to it, and then if a friend has a similar issue as we do, you know, we might pass it on because guess what? If they don't have the coverage and they need the meds, what are we going to do? So I think, you know, to acknowledge that on an individual level, but that, you know, not everyone who is abusing drug is going overscale, and that, you know, addiction and abuse can also be just mismanagement.
That's a really important part of it, that when you give a pill to a friend, you're not thinking of being a drug pusher, but you might be. And owning that and looking at that aspect of how we all play into this issue is so important. Thank you for that. One last revelation. Do we have another student? Okay, go ahead.
Sorry, not a student. My thought was really around the culture of our society today and how much that contributes to it. We're all overworked, overstressed. There's no on-off button. We're on 24/7 because of technology. So whether it's a psychological stress, your body being in stress, you want a magic solution, not something that's going to take more time out of your life. And the idea of looking at alternative therapies, whether it's meditation, relaxation, calming, all of the things that you can do that will take time but can address things that are not popping a pill, that are much more difficult. How can we turn around the culture so that people make space in their lives for themselves to take care of themselves? And this goes also even to physicians. Physicians want you in and out of their office 1, 2, 3. You start to say something, you know, I'm having trouble focusing, give you a prescription. So how can we really change the culture so that we can focus and take care of ourselves in a way that's not about pills?
Good point. And I heard so many people around the room talking about how they could take small steps and big steps with their universities to change the campus culture around drugs, around drinking, around amnesty. So bravo to you for coming up with these ideas. And if some of you would like to take it the next step, the Clinton Foundation has some options for you. This is just hot off the presses. They have just announced the Clinton Health Matters Initiative is going to have a focus this coming year helping university campuses to foster healthier communities through the prevention of prescription drug abuse. So Clinton Health Matters wants students to be a part of the solution. If this is something you feel called to do, if you want to take this discussion and make it not just an idea but an action, here's what you can do next. Email them at healthmatters@clintonfoundation.org. healthmatters@clintonfoundation.org, where you can get support, you can get funding perhaps, you can get organization to do something real on your own campuses. Bravo to you, and thank you so much for participating today.